So now we're going to have a bit of a different, we're going to have a panel. And so I can invite Kate Kunk. She is a caregiver options counselor for SACOA. Dr. NiCole Keith, who is an investigator here at the IU Center for Aging Research, also acting associate dean for the School of Physical Education and Tourism Management. And also Dr. Nikki Monk, who's an assistant professor of health sciences with the School of Health and Rehabilitation Sciences. So a few of us have some slides, a few of us don't. I'm actually also part of the panel. I'm going to walk also. Okay, can you hear me? See, actually, Dr. Keith is always telling us that standing is the new smoking. So I'm actually sitting. I'm sorry, sitting is the new smoking. That's right, not standing. Sitting is. So, and I'm going to stand. So, but actually, so this panel, some of us got together, and the brainchild of this was the fact that we wanted just to give you a little bit of each of our experiences about how we think about doing what we're calling patient-centered research. And mine are just a few stories about how I got it wrong, because if I've learned anything, it's sometimes you learn more from your mistakes than you do from your successes. So I didn't mention this earlier. So in addition to being a scientist here and interested in how we engage the community in research, I have two areas of interest that I study. One is the early identification of cognitive impairment, such as Alzheimer's and dementia, in the primary care setting. So I'm interested in, if we find it earlier, can we actually help the journey for the person with cognitive impairment and for their family member? But I also study medical decision making, and this has been an interest of mine. My story doesn't go back as far as Noel's. I think he said 1970. Mine goes back not quite as far as that, but when I was an undergrad, I was really interested in medical ethics. And the discussion at the time was about advanced directives and patient autonomy, and even a little bit, it was sort of the era of Jack Kevorkian, and it was around a lot of legal and ethical debates. And I was interested in that, and that's really important. And I was convinced that having an advanced directive would solve everything. Advanced care planning is really important, so are advanced directives. But at the time, I thought it was the only answer, and was interested in trying to understand, why some people had an advanced directive, why some people didn't, and how could I just sort of make the world have one? Because, right, if you just told a doctor what you wanted, they would exactly do that, right? So I, as part of my master's degree, kind of engaged some family members. Some of my colleagues had helped me find a few families who had an advanced directive, and then a few who hadn't, because I thought I would sort of do some interviews to understand what helped people with that decision about advanced care planning and advanced directives. And so I remember showing up at a house one day, and this was a couple. She actually had Alzheimer's disease. He probably, looking back, had undiagnosed mild cognitive impairment, but they lived together, and their son had brought them in, and the social worker said, they have beautiful advanced directives. I mean, they are pristine. They're going to get exactly what they want. So I was like, great, I want to talk to them. And I knew that it would be easier for me to go to their house. So I went into their house. They welcomed me in and offered me some tea, and I was talking, and they sort of took me into the kitchen, and I went into the kitchen, and the entire table was just full of pills. I mean, I'm full of pills. I mean, not in a container, not in a pill case, nothing. They were just sort of scattered around, and it was for both of them, mixed in. And I was a bit taken aback, and they're like, yeah, we're just sorting things for the week. And it was just the two of them, and they're pushing things here and pushing things there. And I thought to myself, okay, I started to talk about their advanced directives, and they said, oh yeah, my son had them. We met with a lawyer and everything, and my son, he made sure we had them signed. And I said, okay. I said, well, what about these medications? I said, do you know what these are for? And they're like, well, somebody told me I had to take them. I think I take the purple one in the morning. I take the blue one in the afternoon. And I was like, wow, they have a really good advanced directive, and there is no way they're getting the care that they should be getting. And so it helped me realize that I had this envision in my head about what the right type of thing to study was, until I actually talked with somebody who had a very different experience, right? I went there for one intention, and I realized that without actually being in their space, kind of being in their environment, it really wasn't what I thought it was. And so that was for me way before I learned about anything called like ethnographic research or observational, sort of being in that setting. And so it was sort of the first time for me that I thought, okay, well, I can learn a lot from books and I can learn a lot from my mentors, but unless I actually live and sort of breathe and be in the space that for the people that I'm trying to help, I don't quite really understand their experience. And so that helped change my worldview a little bit. And that was sort of my first experience. The second was when I was sort of well on my way to getting my doctorate. And I was studying medical decision making, interested in how people with dementia and heart disease make decisions about the priorities. Is it if you have heart disease first, what's the implications if you develop dementia later, and vice versa. And so I was studying all the theories that I was meant to study and thinking about what's the right way to think about this. And in my mother, who was a caregiver for my grandmother, at this point, actually, my grandmother had moved into a nursing facility. She had lived at home as long as possible, and the very traditional path, right? Whereas each week my mom gets a little bit more and more involved, and before you know it, she's basically doing everything. And so she moved into long-term care. About 25 years prior to that, she had gotten a pacemaker in her 60s, and it was very much the right decision at the time, right? She was a vibrant 65-year-old who was still working and, needed a pacemaker for her heart. And it was clearly the right decision. Well, on a really cold, snowy, icy day in Western Pennsylvania, my mom, treks over to the nursing home, 8:30 in the morning to try to rouse my grandmother out of bed with the help of the staff, get her cleaned up, get her, loaded up into the wheelchair van. She says they slid sideways down the hill to get to the cardiology office because they had called the week before and said it was time for her to get her pacemaker checked. So then my mom says she bites that harrowing example of getting her in there. Of course, unfortunately, my grandmother had an accident. My mom didn't have a change of clothes for her. She's trying to get her cleaned up in this tiny little bathroom outside the cardiologist's office. And they finally get in there, and the cardiologist, they wave the magic checker, across everything. And they said, oh, yeah, she's good. Battery's fine. A 3-minute appointment. And my mom's like just looking around thinking, all right, it took me 3 hours to get here. We just had this 3-minute appointment. She loads her back in. She gets her back to the nursing home, and she's exhausted. Everybody's exhausted. And she tells me the story later. And remember, I study medical decision-making about heart disease and dementia. And I said, what would have done if the cardiologist said, she needs a new device or she needs a new pacemaker? And my mom says, well, we wouldn't do that. Why would we do that? And I said, well, why did you take her? And she was like, I can't believe I just succumbed to it. And it made me realize she has the best intentions for her. She's a really well-educated and trained caregiver. And she fell into the trap of doing, the same kind of emotion and the same, inertia that the healthcare system. And so it made me think about, it's not just, providing information to somebody or not just, having an advance directive. It's actually really being able to understand the entire system around the decision. And so I have luckily, I guess, had these two sort of personal fails that I was able to really help think about what caregivers of older adults with cognitive impairment really think about when they think about medical decision making. And so I know that the research that I do is always sort of informed by that. And my motivation to have all of you here today and why I try to spend as much time with caregivers as I can is to really learn what's important to all of you. So I'm going to actually pass it over to Kate. And, there isn't a universal theme as much as it is we kind of all talked and sort of said, we just wanted to share our stories about why, we think being engaged and really in the moment, I guess, with the people we're trying to help is important. So.
Yeah. We can't figure out how to keep that on.
Keep it on. Sorry, Kate.
Good morning, everyone. It's quite a privilege to be here this morning and talking to you, and it's one that I don't take lightly. So thanks very much for hearing what I have to say. Hopefully it will be meaningful. I decided to, if you'll bear with me just one moment, I'll get the slides up. I have 4 whopping slides, and we'll see them in 1 second here. I decided to talk about obstacles today. Obstacles to individuals and their caregivers, and to research and development, perhaps. Obstacles to independence, dignity, and quality of life. And so how many of you can say the name of your local area agency on aging today? How many of you cannot say the name of your local area agency on aging? Be brave. Okay, good. Well, SACOA covers 8 counties in central Indiana, Marion County, and the 7 surrounding counties, as many of you know. And these are some of the services that we provide to individuals who are older or have a disability, who have these needs that would present obstacles in their lives, obstacles to independence, dignity, and quality of life. So we have to recognize also, though, that if we can meet needs with services like these, very often we are going to be providing respite to the caregiver. So we serve the individuals and their caregivers. But we work directly with caregivers as well. Very often people are trying to keep someone at home who is quite ready for a nursing facility. And they're just really struggling to kind of keep going. And as a matter of fact, as you probably know, caregiver burnout is the second leading indicator for premature preventable nursing home admission. And so if we can prevent caregiver burnout, and if we can prevent falling for that matter, which happens to be the #1 leading indicator for preventable premature nursing admission, then we're in really great shape. We should be able to keep a lot of people in the community for longer. So they get these services that are for the older person, and then we also have direct supports to caregivers that include, but are not limited to, the RCI REACH program at SACOA. RCI stands for Rosalind Carter Institute. REACH is an acronym that it stands for Resources Enhancing Alzheimer Caregiver Health. However, we really serve anyone with any variety of dementia or any diagnosis causing dementia. And these have to do with stress reduction, self-care, skill building for dealing with those problem behaviors. And by the way, SACOA was just chosen to host a dealing with dementia training for some of its staff. We were one of 20 sites chosen nationwide for this special training, and we're really looking forward to that in July. So we've talked about obstacles to individuals, their caregivers, to research development, and I would like to add another type of obstacle that we don't talk about very much, but I think that we need to show the insidious obstacles socially with regard to ageism. And I don't know quite how to put this slide up here, but as if it were not enough that we have other kinds of obstacles, we have Halloween costumes, we have over-the-hill party things. And I bring this up because these kinds of things really plant and perpetuate a mindset in this society that is totally inappropriate if we want to keep well seniors well. I see it so often when older persons begin to buy into that kind of, well, I'm almost 80 sort of mindset, and that's really kind of deadly. And I think that we can spare ourselves quite a bit if we can train from very early on. And this becomes part of prevention, which is so important. You know, if we don't start early in life for children to understand that, you know, being a certain age is not helpless. It's such a simple thing, really. It's very simple. And looking around this room, I see all ages represented. The interesting thing is that we cannot know for sure what it's like to be an older person until we're actually there. And then once we're there, we are unique. We can't just keep speaking of, those people. And so what I would like to see us do is continue to bring more and more seniors to the table so that we're not just talking about them, but they actually have quite a bit to contribute and are part of the dialogue at the table. So let's keep everybody engaged. This little girl is the daughter of a woman in her 30s who's a doctoral candidate at an Ivy League school. And I saw this on Facebook. Her grandmother posted it, and I was a little overwhelmed. As adorable as that is that child not the cutest thing you have ever seen? And yet, what has she learned? What is she going to continue to perceive as she grows throughout life? And so I would like us to take a really healthy and realistic look at what we want from seniors in terms of their ability to contribute so that we are all there at the table. Let's do what we can to keep them here so that we don't have to continue to discuss them as those people. And that's about all I have to say about that, but I think it's an important piece. So SACOA is all about meeting the issues and obstacles related to elderly and those with a disability and their family caregivers. SACOA, by the way, has 2 poignant workshops that are related specifically to ageism in America, if you're interested in the topic. One is for seniors themselves, seniors fighting ageism, for well seniors. And one is for HR departments in commercial entities, wherever there are customers that are likely to be older people, or for coworkers and in government and so forth. So we do enjoy providing those to people. And I would be remiss if I did not mention a very important program at SACOA that is actually spearheaded at SACOA called Dementia Friendly Indiana. And how many of you have heard of Dementia Friendly Indiana? Okay, so some of you have been through the champion training, right? And so you understand that this is to reduce stigma, because folks with dementia need that, they need to be able to participate in a way that is not stereotyped. They need to be part of society, and that is the goal there, to reduce that stigma and stereotype. So I think that concludes about all I would want to say, and I want to thank you very much.
Dr. Keith, do you have slides, or we're just going to...
Okay, I'm going to talk from here, and if you can't see me, I encourage you to stand up so that you can. Again, my name is NiCole Keith, and I've been with IU Center for Aging Research for about 15 years. I came to campus as an assistant professor in the Department of Kinesiology in the School of Physical Education and Tourism Management. But I first just wanted to make a comment on something striking that Kate said, and that is that I am really a fortunate person in that I have the opportunity to live with my husband and my dad. My husband and I have lived here for 15 years, and my husband is 68 years old and my dad is 74 years old. My husband and I share 4 children who range in age from 23 to 15. And about 2 years ago, my dad started having health issues. He was living in Atlanta, and didn't have any family there. Our family's all in Chicago. And I said to my dad, you need to move back north. You can come live with us, or you can go back to Chicago. Either way, you need to be closer to the family because you're having a lot of significant health issues. However, we have the best geriatric care in the nation. And so I recruited my colleague who's in the back, Dr. Jennifer Carnahan, and she is now my dad's primary care physician. And he gave us permission to communicate about his health. And I remember one day I was sitting in my office and Jennifer said, I need to talk to you. And we talk about a lot of things, so I had no idea what it was about. And she put a series of cognitive tests on my desk and said, this is your dad. And I looked at the tests and I said, that is absolutely my dad's handwriting, but that's not my dad, that he had mild cognitive impairment. And so he started seeing Dr. Callahan, who you've met this morning, and he's an awful patient. They will both tell you. No, actually, Jennifer told me he's doing much better now. But the other part of this is that my kids, and this brings me to what Kate said, don't understand how daddy and granddaddy are so close in age, but so different. Like, what happened to your dad? And it's a really great question, which brings me to my area of research. My area of research is physical activity and aging. And so what happened to my husband is he met me. And we work out all the time. He exercises, and I know he's a lucky guy. He coached football for 32 years, and he always tells his friends, I outpunted my coverage. He did. Anyway, part of it is physical activity and aging. And I'm glad that Dr. Campbell came back into the room because now I can say it to his face, and you would all say, oh, you're talking about him behind his back, but I'm not. We're really good friends. But I thought it was really striking in his presentation this morning, and I wrote it down, that he said, it's pretty hard to change diet or exercise. And I was like, really, Noel? Do you think so? And so how many of you walked in here today? I should see you didn't walk in here. Like, how did you get from the front door to this table if you didn't walk? Tell me, because we could sell that if you can tell a transport. Most of us can walk. About 95%, according to the Centers for Disease Control and Prevention, of Americans can walk. And so that is what I promote in terms of physical activity, is walking. And if we take every step as a future contribution to our health, if you think every step I take is a future contribution to your health, you can live longer and age well. So I came here 15 years ago as a bright-eyed assistant professor, just saying all I have to do is give people education. As long as I tell them what they can do to be healthy, they'll do it. I was so naive. And so I started going, and Dr. Callahan has been my mentor since the beginning, and he said, you really need to start shadowing primary care physicians in the clinics. So I started going to the Eskenazi, at the time, community health centers, or Wishard at the time, community health centers, and listening to primary care physicians talk to their patients about being healthy. And they would always refer them to the dietitian. But 2 weeks of this, and I never once, 2 weeks, 8 hours, listening, sitting into, it was fascinating. Got to see all kinds of cool things. But listening to patient-provider visits, I never once heard, you should walk. Didn't hear it. And so I finally asked the question, and they said there's nowhere to do it. And so I started talking to the patients about if you could walk, where would you walk? And they didn't know. And most of the time I was at Westside Clinic, and there are really great connected sidewalks all over that community. And I said, well, why don't you just walk outside? And so 15 years ago, for those of you who are around here, there was a wild dog problem that I was unaware of because I didn't live in that neighborhood, but I live in Wayne Township, so I had to drive over every day. And so I started seeing really these packs of wild dogs running around together. And I thought, oh yeah, that's kind of scary. I wouldn't walk out here either. And the city finally took care of it when the dogs got into the zoo and killed an animal. And so you don't see those dogs anymore. But you look shocked. It really happened. But what I learned from that is the only way I'm going to get people to be more physically active is to talk to them about what they might do, what they can do, And even though 95% of Americans can walk, about 32% do to the level that they need to. And so to learn from community constituents about what they will do, and it might not be walking, it might be something else, and then how we can, as Noel commented, nudge them to do the right thing. I also heard I can't remember your name, I'm sorry, about education in medical schools for physicians. And so part of that is my work too, is getting physical activity into the medical curriculum through an initiative called Exercises Medicine through the American College of Sports Medicine. But really talking to constituents, all of which Nicole described, or all of whom Nicole described this morning, about how to get people to be more physically active and to learn from all of you about what might work, because I'm still learning. I have yet to get this right. It works for some groups and then it doesn't work for other groups, or it works for groups for a finite amount of time and then we lose them. And so learning how to get people more physically active, because education isn't working. I now know that's not enough, that we have to do more and we have to come from different angles. So I hope to hear from you after we hear from my colleague, Dr. Nikki Monk, about what we can do better to get people to be more physically active and successfully age.
All right, I did bring some slides, so I'll pull those up here. And I should have taken pointers from Noel as far as speaking on time. My slideshow is really, really long, but we're going to fly through some of these slides to get sort of to the meaty points, if you will. So I'm Nikki Monk. I'm an assistant professor of health sciences. I'm not associated with IUCAR at this time. But these are just some of my affiliations. I think the big piece to take away from this is that I'm clinically trained in massage therapy. That doesn't live in the university or in academia at all. But my doctoral training is in gerontology, so that long-term lens. And I'm also very, very interested, absolutely, in current older adults. But I'm also very interested in future older adults, which includes all of us, hopefully, right? Including children. So always looking at it across that spectrum. Now, massage therapy, I'm sure you guys are familiar with the term. It's actually an umbrella term for a whole lot of different modalities. And massage therapy fits into this concept of complementary and integrative health, or medicine. And you can put these into two buckets, if you will. You've got the self-applied pieces these are the things that are on top, your herbal practices, potentially yoga, meditation, Tai Chi, and the like. But then you've got practitioner-provided pieces, and that's your chiropractic, massage therapy, acupuncture. And one of the things that we know is that complementary integrative health practices, including massage, are rising in the older adult population. And particularly around massage therapy, the reason for that is that as baby boomers are aging into older adulthood, these have historically been the people who have most utilized massage therapy, depending on where they were in their life course, because they were the ones that had more of the disposable income and the like, and cumulative time and exposure to that. So we can expect that future older adults are going to be using it more, because it is something that perhaps their perceptions are different, more accepting of it, and they've also used it in their lifetime. So when we think about massage therapy, these might be the sort of images that we get, and apparently only really pretty young people get it. But the fact of the matter is that massage, and that's not to say anything against the people who are receiving it here, but this is really what massage therapy actually looks like. It is received by lots of different types of people. It's received not just on the beach with people looking so relaxed with their head tilted to the side, but no, it's in different levels of dress, also different, whether it's sitting in a chair or on a special massage table or what have you. And this, I think, is a more realistic image of the massage experience. Massage therapy can be applied in several different health strategies, and these are the four top ones here. So we've got from a preventative perspective, so wanting to improve wellness, be able to retain the function that folks have, and then also just in general to decrease stress, right, which is overall will help with wellness. From a curative standpoint, this could be for pain, potentially depression, anxiety, or other sorts of pieces that there is an issue that can go away, all right? Now, one of the things that drives me absolutely bonkers is when integrative practice practitioners will say, this piece can cure diabetes, or it can cure this or that. And massage therapy isn't going to cure your diabetes, right? So this isn't something that would fit in here. But this is also a piece around pain, that this is another piece for me as a massage therapist and also somebody who has a chronic pain condition. I have scoliosis that I manage, but massage therapy isn't going to fix the curvature of my spine. That is only going to, so this is all to say that this pain piece can actually fall in this curative, can also fall in the next one, which is rehabilitative, so something that needs to improve after injury. But then it can also fall in the supportive piece as a way to for maintenance. So I'm able to manage my pain through massage therapy or something else that's from my scoliosis. So there is something that, regardless of how you're applying massage therapy, that is fundamentally true for all of these. Can anybody think of what that might be? I will tell you, it is touch. Bottom line, whenever you're doing massage therapy, touch is the basis for that. And when we think about touch for kids and babies, we know how important that is, right? We've seen the literature on if you have children who are neglected or aren't touched, that there's some pretty negative outcomes. But one of the things that we don't get to hear, so how come? There's lots of reasons for that. One is it helps to promote sort of the feel-good juices, if you will, helps to decrease some of the not-so-good juices as far as stress and the like. But I asked the question about when is it that we stop needing touch? If it's so valuable and important for children and babies and their development and their thriving and the like, when do we stop needing it? And we don't. But yet, the older adult community is one that over time we get less and less touch, right? Whether it be because our society doesn't allow people to touch anymore. In fact, coming in, I saw a couple standing at the bus stop, and they were just holding each other. They're just holding each other. It's like, wow. And I realized that it struck me, first of all, that they're just standing out there holding each other, right? But it's not something that we do. And as folks potentially either are losing spouses or they're no longer having the ability to have intimate contact, or even outside of intimate contact, just touching people. We don't do that very often. And so being able to bring this to older adult community, even if we take away the other pieces that massage might bring, it is a way to encourage and provide caring, nurturing, unconditional, positive regard, just touch, that human contact that we so oftentimes lose. Very quickly, this is a research study that I did while I was a doctoral student. This was just looking at older adults who had and had not had massage over the past year. And across every spectrum, in fact, these were folks that had persistent pain as well. Those who didn't necessarily report pain, we saw that there were differences in their emotional well-being across. Now, but this is the RAND 36 that looks at all manner of different quality of life indicators, functional quality of life indicators. And those who had had massage scored remarkably better than those who hadn't. And now this isn't causative by any means, it's all correlative, but it just sort of sets the premise that having even received massage therapy might, this also held when we accounted for differences of income and the like. In general, massage has been studied in lots of different populations. These are several of the populations, and the evidence is pretty good overall. Although we do know that the research is not terribly strong as far as the sample sizes and the like. But we have had a really nice systematic review come out recently that was looking at massage for the general pain population. But pain is a place where we've looked at quite a bit. There's a lot of evidence for this, from chronic low back pain to also cancer-related pain, other musculoskeletal pieces, headache, fibromyalgia, and this is across the different age spectrums. We also have emotional health and mental health pieces that are, and these are the different patient populations that has been studied in. Now, when we look at it specifically for older adults, there's some limitations here, because oftentimes older adults are even excluded from some of these larger trials. It's like you have to be under 65 to be a part of some of these research pieces, so we don't necessarily know all the outcomes for that. There's also pieces around, but other adult-specific pieces that we do have some evidence on is some dementia-related, also balance and falls, mental health, and then general function, so range of motion and grip strength and the like. Needless to say, there's not very much, and there's huge gaps in the literature, so big we could drive a Mack truck through it. But some impact opportunities for older adults, I've just sort of put some pieces up here to show where it could potentially insert. I love this. This came from, let's see, this is Chris Check's Learning to Be Old from a psychosocial from gerontology. And she said that massage is so beneficial that Medicaid should cover it. We're going to have shorter recovery periods from surgery and illness, stress reduction, delayed onset of serious illness, and it goes on. And it's really great accolades for massage therapy. Unfortunately, though, it's not necessarily evidence-based. And so we really do need some of those evidence pieces. I wanted to add very quickly, this is some new literature that has come out that isn't in older adult population, but it has huge implications for older adults. And the other piece is a little challenging, is that this is actually a massage model that's done in rats. But I want to tell you guys what this was. And this is some former colleagues that I had down at the University of Kentucky. And what they did was they induced muscle atrophy in rats, and then they either allowed them to reambulate, or they reambulated and they did a massage 3 times a week on their legs. And what they found was that from a muscle rebuilding standpoint, yes, reambulation was great, but it was significantly better when you added that cyclical compressive loading. I want to add one more piece to this. Not only was it great for the limb that was being massaged, they only massaged one of the limbs. They also looked at the other limb, and reambulation, it was just as well, right? Both sides got that. But the one that got massaged, even though the other leg didn't get massaged, it also had significant muscle regrowth and rebuilding. In other words, the benefit that was being done on one leg was transferring over to the other side. And this is something called the crossover effect. You can imagine how huge this could potentially be on many levels, right? One, from the standpoint of somebody who might be at risk for losing muscle, that massage therapy might be able to help rebuild some of that muscle. Or if there's an area that can't necessarily be addressed, such as an acute injury, if somebody is recovering directly from hip surgery or something like that, you could still massage the other side and potentially get some of that benefit and regrowth on the other side. Again, this has only been demonstrated in animals at this time, but I think it has some really profound potential implications for the field. Now, from a standpoint of being able to access massage, there's a lot of barriers, and I'm sure that we are all very familiar with that. One of the big pieces is that it's not accessible from an insurance coverage standpoint. Medicare and Medicaid doesn't cover it, out-of-pocket costs. There's also transportation and logistical issues. And there's also this issue of we do have some ideal dosage that we've determined through research, particularly for chronic neck pain. So in order for chronic neck pain to be addressed significantly with massage therapy, you need 3 hour-long massages per week for 10 or more weeks. That sounds awesome, right? You can sign me up for that. But again, it's not covered by insurance. That's out-of-pocket cost. And then even from just a logistical time frame, how can you even get there, right? So there's ways perhaps that we need to be able to overcome these. And this is where I think community-based research can be really, really helpful, because we can do pieces like self-care or ally-assisted care. And this is where my research has been going. I'm going to skip through these pieces and get to some of the work that I've been doing is looking at teaching people how to do trigger point self-care and provide their own massage to address their pain. These are just some of the outcomes that we've had in this. I really don't have time to talk about it, but I'd be happy to in a break around this. Another piece that we're doing in the Veterans Administration, we've got a Tomcat study where we're teaching care allies how to give a care-assisted massage, 30-minute session. The veteran is doing some of their own work, and then their care friend is doing another pieces of that, and this is something that is in progress. And we're also taking this through the MAMA study. This is massage for maternal anxiety. And this is being done at Monash University down in Australia. And we're helping care partners for women who are pregnant through their pregnancy to see if we can reduce some of that maternal anxiety. So it's a model that we can look at massage. We can bring it to community, but then we can also look and see how effective, applicable, and accepted it would be in those communities. And I don't know what's next, but I'm excited to see it.
Thank you. So we have a few minutes before our break. And so if there's any questions for any of the panelists, or actually anything that you've kind of popped into your brain so far this morning.
My name is Henry Price. I'm a caregiver for my wife. And I wonder if there is any way to use any selective criteria to find a qualified massage therapist who would be beneficial to prevent caregiver burnout.
That is an excellent question as far as like how to find a qualified massage therapist. There's several different groups, the American Massage Therapy Association and the Association for Bodywork and Massage, ABMP are the acronyms, that have massage finder features for their institutions. And these are from all over the country. These are folks who have received a national certification. They've also gone through the appropriate training for massage therapy, or what is current training standards for massage therapists. Indiana is a state that is going through its credentialing growing pains, if you will. They used to be a certified state, now they're a licensure state, and they're working through that. So one of the pieces that you would want to know is whether or not where they're trained, how they're trained, and potentially if there's a population-specific need that you have, if they have experience with that. But I also be happy to send you some resources if you would like. You're welcome.
I have a question for all of you. So given that we've talked about how everybody in this room is some sort of stakeholder, how do you think about yourself in sort of your role that you have? How would you like to be involved in research? I mean, I know we only have like 2 minutes, and so, it's kind of a big, lofty question. And maybe I'll just plant it for later, because maybe I'll ask it again. Because, our goal was to sort of have you hear about some of the things that we've done, talk about how we've tried to engage people in research, but we're still learning from all of you.
So my follow-up question to Nicole's question, and it hasn't been lost on us how our names all go together. So Nicole, Nikki Monk, and Kate Kunk, we get it.
We did this intentionally so you would remember us all.
So my question is to you is, why did you come today? Because part of a challenge that we have is engaging with people. And this is an excellent turnout, and we're very thankful for you for coming today. But what was it that got you here? Because we need to duplicate it or replicate it. We need to bring you back and engage with you more. So if you could share with us what it is that made you decide to come today, that would be really helpful.
I think there's one question over here.
Just real quick, I've often thought about massage chairs in nursing homes. So do you have any comments about massage chairs?
It is a really nice medium to be able to use, particularly for folks who might have some limited mobility, but there is still the necessity to be able to get into that massage chair. And I would actually more consider doing other adaptive massage techniques. So rather than investing in a chair that some folks may or may not be able to use, to be able to have programs or therapists come in and use what's already there. So if somebody has a chair that they can be comfortable in, being able to receive some sessions that way. And also, it depends on how long that session is going to be. If it's going to be, 10, 15 minutes, if somebody was sitting comfortably in a chair, it would probably be more beneficial for them to just, do hands and neck and just some nice strokes, and then they don't have to go through that whole piece of getting in and out. So that's how I would, yeah. Mm-hmm.
I worked at a nursing home in Virginia, and I was very fortunate that we were able to do integrative medicine, including hiring several massage therapists and having a massage therapy room in our outpatient department. But the finances was an issue, but we were able to, through some work, get some donations so that the people who couldn't pay privately could receive massage. And our massage therapist did some of the massages in the room, in the bed, but we also had other ways of doing massage. We never used chairs on our patients. They were usually, prone to supine in bed, and we found it very successful. And I left in 2014, and I was talking to one of the massage therapists, and she said they're still getting more funding, more donations, because they found the program so beneficial. And we did end of life, all those things that you talked about, for our people that lived in that particular facility. So it can work, and it can be extremely successful.
Hello. My name is Delisha Stevens, and I work for PhysioCare Home Health. And the reason why I want to entertain your question, the reason why I came here was personal and professional level. Personal because my grandmother had Alzheimer's dementia, and so interested in the research and all of that. She passed away, and so it's all about, different things, your family traits, ways that we can support each other in the community, whether they're after effects when a family deals with, caregiver burnout, or someone that has handled a family member with Alzheimer's or dementia, or, what happens in the brain that makes you do the things that you do over time. And so when we talked about activity, my grandmother was a homemaker, and it kind of triggered for me, she didn't do much activity, and so she got early onset dementia, and that was her late 60s. And so it carried on for about 20 years, and she recently passed away. And so I was interested in the dynamic of that, but interested to find out what we could do as a community to really help support people here in the metropolitan area and surrounding areas in Indianapolis. On the professional level, on the home health side, I want to be an educator and an advocate, someone who can go out to express what I've learned and to make sure we connect them with the proper resources.
Well, that's great. I think that we are going to wrap up this part of the day with actually a big break. So, sometimes you go to meetings and they give you 2 minutes to run to the restroom. We gave you 30 because we want everybody to take the time, do some networking, have some breakfast, and give us a chance to kind of move around a little bit so we're not sitting so much. The restrooms are actually around the corner next to the elevators, and there's still plenty of breakfast out there. We're going to give ourselves 30 minutes. We're actually going to be showing some videos as you kind of come back in. You can take a look at the screen, and then we'll convene at 10:30.